Today we'll be discussing trigeminal neuralgia and exploring two complementary alternatives to standard treatment. Trigeminal neuralgia, or TN, also known as tic Douloureux or the suicide disease, is a neuropathic chronic pain disorder that affects the fifth cranial nerve. The trigeminal nerve contains three distinct branches: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. TN is characterized by stabbing or electrifying unilateral facial pain following the sensory distribution of the trigeminal nerve, affecting one, a combination, or all three of the trigeminal nerve branches. Trigeminal neuralgia presents as attacks of stabbing or electrifying unilateral facial pain following the sensory distribution of the trigeminal nerve and is often accompanied by brief facial spasms or tics. Patients can localize their pain precisely to the affected branches of the trigeminal nerve. The pain is described as severe, spasmodic, and piercing, and is often depicted as electrical shocks radiating down the nerve. This shock-like pain lasts for approximately 20 seconds, then changes into an excruciating discomfort felt deep in the face, often contorting the person's expression, seen as grimacing or wincing, and then gives way to a burning ache lasting seconds to minutes. The pain fully subsides between attacks, even when the attacks are severe and frequent. When frequent attacks occur, the previous attack leaves the patient exhausted and unprepared for the next attack, which subsequently increases the intensity and the perceived pain during the next attack. The number of attacks may vary from less than one per day to up to hundreds per day. Attacks are often triggered by normal behaviors such as talking, smiling, eating, drinking, taking a shower, brushing your teeth, washing your face, blowing your nose, being in a cold environment, or having wind on your face. Being physically active, being overly tired, and being stressed can also contribute to attacks. Trigeminal neuralgia impacts approximately 1.5 individuals out of 10,000 people per year, with about 15,000 cases per year. Women are twice as likely to develop trigeminal neuralgia. The reason for this through research is still unclear. However, through gathering information from an online support group of over 5,000 trigeminal neuralgia patients, it is plausible to link the hormonal fluctuations women encounter as the likely key factor. For 90% of trigeminal neuralgia patients, onset of symptoms begins after 40 years of age, with typical onset occurring between 60 and 70 years of age. Patients who present with earlier onset, between 20 and 40 years of age, are more likely to be diagnosed with multiple sclerosis. Trigeminal neuralgia in most cases is multifactorial. Usually there is some type of compression caused by a blood vessel, tumor, or scar tissue. Demyelination may occur if the compression of the nerve continues over a long period of time, continuously wearing down the nerve fibers. Nerve lesions may be caused by vitamin B12 deficiency, multiple sclerosis, Lyme disease, and sarcoidosis. Nerve damage may occur from dental procedures, head trauma, and damage during medical or surgical procedures involving the head. Exact pathophysiology is controversial and is considered idiopathic for classic trigeminal neuralgia. Etiology may be considered central, peripheral, or both. Trigeminal neuralgia is divided into two categories: classic and symptomatic. The classic form presents with swift onset and is most often found to involve compression of the nerve by blood vessels. This compression results in focal trigeminal neuralgia nerve demyelination. Symptomatic forms can have multiple origins, which include aneurysms, tumors, chronic meningeal inflammation, or other lesions may irritate trigeminal nerve roots along the pons, causing symptomatic trigeminal neuralgia. Pain sensation is associated with nerve function of the trigeminal nerve when the nerve is injured or demyelinated. Pain mechanisms are altered, associated with lack of inhibitory inputs from large myelinated nerve fibers, which subsequently causes an amplification in sensory inputs. September 20th, 2008, I was sitting in my office working on a patient chart when I felt a sudden shock that radiated from the center of my brain that led to a stabbing pain in my jaw and ear. By October, I was going to the doctor's office on a weekly basis. In November, my visits increased to 2 to 3 times per week until my local clinic finally referred me to an ear, nose, and throat practitioner. He sat patiently with me for 45 minutes listening to my symptoms, and then after observing an attack, he jumped up and ran to his office and brought back a medical book and explained to me that he believed I had tic douloureux. He prescribed Roan and referred me for an MRI and to the neurologist. The MRI revealed a loop of blood vessels surrounding the nerve, and when visiting the neurologist, I was diagnosed with classic trigeminal neuralgia. A few lesions were observed in my MRI, so I received extensive testing to rule out multiple sclerosis, as I was 31 years of age at the time of my diagnosis. During my first microvascular decompression, it was found that I had scar tissue that was actually holding the blood vessels against my nerve, causing demyelination. Conventional treatments include pharmacologic therapy, percutaneous procedures, surgery, and radiation therapy. Pharmacologic therapy includes anticonvulsants that are used to block nerve firing, slowing down the nerve's conduction of pain signals, antispasmodics used to relax muscles and used in conjunction with anticonvulsant drugs, and Botox that is locally injected at specified trigger points. Medications are usually effective at onset of trigeminal neuralgia, but become less effective as time goes on, often requiring a dosage of increased and/or combined therapy. These drugs have many known side effects and are not well tolerated by some patients. For me, the side effects were very extreme and included dizziness, nausea, confusion, drowsiness, double vision, and dysphagia. For 3 years, I was unable to drive because of my drug regimen for trigeminal neuralgia, which consisted of Tegretol, an anticonvulsant, and baclofen, an antispasmodic. In the end, the drugs were affecting liver and kidney function and were discontinued after my last brain surgery in 2012. Percutaneous procedures include glycerol injections and balloon compression. Both procedures are done by inserting a needle through your face and into an opening in the base of your skull. Both procedures are used to damage the trigeminal nerve and may cause numbness and/or muscle weakness. Surgery includes microvascular decompression, which is a procedure that leaves the trigeminal nerve intact by focusing on the removal of the compression or insulating the nerve from the compression. A trigeminal rhizotomy involves damaging the nerve fibers to block pain signals, and a trigeminal neurectomy involves severing the trigeminal nerve at peripheral locations V1, V2, V3, or severing the nerve at the root involving the whole nerve or just the sensory portion of the nerve. All surgical procedures involve risks which include infection, a spinal fluid leak, damage to other cranial nerves, stroke, facial numbness, facial weakness, and/or anesthesia dolorosa, which is usually associated with a trigeminal neurectomy. I have underwent 3 open brain surgeries, my first being a microvascular decompression in 2009, the second was a microvascular decompression with a trigeminal rhizotomy in 2010, and the third, which took place in 2012, was a trigeminal neurectomy of the sensory part of the nerve, which has since regenerated. I had many complications associated with surgery. I experienced damage to the other cranial nerves, which caused occipital neuralgia, masseter muscle spasms, facial drooping, and dysphagia, a spinal fluid leak, facial numbness, and anesthesia dolorosa. Radiation therapy includes radiofrequency thermal lesioning, a procedure that involves gradually heating the nerve with an electrode until damage to the nerve fibers occur, promoting sensory loss, and stereotactic radiosurgery that involves focusing direct beams of radiation on the trigeminal nerve, causing a slow formation of a lesion to disrupt transmission of sensory signals to the brain. I underwent stereotactic radiosurgery in 2011, which produced worsening of symptoms, but had to heal before the trigeminal neurectomy could be performed. Complementary treatments are usually used in conjunction with traditional therapies and include electrical, mechanical, and thermal stimuli, acupuncture, upper cervical chiropractic care, meditation, creative visualization, aromatherapy, biofeedback, low-impact exercise, yoga, and nutrition and vitamin therapy. Meditation and mindfulness has been my go-to line of treatment for the last 4 years, along with biofeedback, acupuncture, craniosacral therapy, yoga, and nutrition and vitamin therapy. I focus on reducing the symptoms and staying positive. It is amazing how our bodies adjust to chronic pain by maintaining standards pertaining to quality of life. You can find a new path, and positivity makes even small wins worthwhile. There are no recent studies focused on natural product therapies for trigeminal neuralgia. However, vitamin B12 has been linked to trigeminal neuralgia as far back as 1951. With trigeminal neuralgia searches producing limited results, I searched for natural therapies associated with neuropathic pain. We will now discuss the effectiveness of vitamin B12 taken orally and injected, and capsaicin patches and their impact on neuropathic pain. Zhang et al. Notes that recent studies show that vitamin B12 plays a key role in the functioning of the brain and nervous system because of antioxidant and neuropathic properties. Vitamin B12 deficiency is a known cause for neuropathic pain. It is important to remember that vitamin B12 is not used directly in the human body and must be translated into activating forms such as methylcobalamin, which promotes injured nerve and axonal regeneration, improves nerve conduction velocity, and inhibits ectopic spontaneous discharge. In the Zhang et al. Review, it was noted that among other neuropathic pain conditions, trigeminal neuralgia patients found relief and pain was significantly reduced in the methylcobalamin group. Vitamin B12 supplementation is well tolerated when given orally and when injected, and should be considered as a viable option in neuropathic pain management in conjunction with other therapies. Capsaicin is a highly selective, potent, and high-affinity exogenous agonist for the activators of TRPV1. An 8% capsaicin patch applied for 1 hour effectively targets the nociceptor, leading to localized defunctionalization. Capsaicin decreased pain by 30% in 100% of participants and reduced pain by 50% in 50% of the trigeminal participants. Both studies' treatment groups used an 8% capsaicin patch, which was found to provide rapid and effective pain relief for patients with neuropathic pain, including trigeminal neuralgia. Capsaicin had fewer side effects with faster onset of action than medications used to treat neuropathic pain. An 8% capsaicin patch was well tolerated by most individuals, with site pain during application and a burning sensation being the most reported side effects. Some patients required a numbing medication for application related to discomfort. The use of B12 for neuropathic pain is highly promising but warrants further studies with larger base participant groups that can be generalized to the population of neuropathic pain patients. The use of vitamin B12 as an adjunct therapy should be considered on an individual basis based on B12 status and the level and longevity of neuropathic pain. An 8% capsaicin patch was found to be highly effective in the reduction of neuropathic pain, including TN, and well tolerated by most individuals. It would be interesting for future studies to focus on trigeminal neuralgia alone to really establish clear-cut effectiveness for facial pain, as the cited studies included only a very small fraction of trigeminal participants. Both CAM therapies should be considered for trigeminal neuralgia patients on an individual basis with consideration with all other treatment options. With known drawbacks of current trigeminal neuralgia medications and with the waning efficacy of the drugs for long-term use, it is actually surprising that more natural product therapies are not being explored and studied for the treatment of trigeminal neuralgia. Such a chronic condition that is described as one of the worst pains known to man would lead you to think that effective treatments would be highly sought after. Thank you for your time learning more about trigeminal neuralgia and listening to my personal story. Please feel free to ask questions.